Well, I am Bunny Ellerin, and I run New York City Health Business Leaders. So welcome. We're here today to talk about the evolution of urgent care. Is Click-and-Mortar a better model? Now, we as New York City Health Business Leaders have been tracking the expansion of urgent care for several years. In fact, we hosted Richard Park maybe 5 years ago. He was the founder of CityMD as they were growing, and he predicted then that consumers would continue to demand better and faster access to treatment. And that has absolutely proven to be true, particularly in light of COVID. In fact, estimates found urgent care up by 58% in 2020 due to demand for COVID-19 related services. So we'll be talking about the evolution today. We are so lucky to have 4 fantastic panelists, and so I would like you to meet them. First, Dr. Eve Duraso, who's the chairman of emergency medicine at Lenox Hill. Eve, would you just do a brief intro? And you can go off mute.
Thank you very much, Bunny. So I'm the chair of the emergency department at Lenox Hill, which is part of Northwell Health. And I also have a vice president role for the Western region of our emergency departments at Northwell Health. Thank you.
Next up is Dr. Sonny Morton, who's also an emergency room physician. And today he's senior medical director with CVS Minute Clinic. Sonny, would you like to do a brief intro?
Good afternoon. Happy to be with you today. I have been with CVS Minute Clinic since 2007, when it was a much smaller operation than it is today. And before that, I did spend 20 years as an emergency physician.
Thank you. Next is Vivek Taparia, who's the president of the New York market for GoHealth Urgent Care, and somebody I've known for many years.
Thanks, Bunny. Vivek Taparia, I'm the New York market president for GoHealth. We run 54 urgent cares in partnership with the Northwell Health System, spanning from the Hamptons to Staten Island to Westchester. It's been very fulfilling being on the front lines of the pandemic, providing access to testing and vaccinations over the past few years. I actually have had the opportunity to work with almost every urgent care chain in the New York City area. Before I came to GoHealth, I ran the urgent care network for Optum Tri-State, including the urgent care network for ProHealth. And then while on the population health team of the Catholic Health System, I ran their partnerships with CityMD and PM Pediatrics. So looking forward to today's discussion.
Fantastic. And last but absolutely not least is Julian Dubuis, who, before you talk, Julian, is on our advisory board, has been a huge supporter of New York City Health Business Leaders, is a digital health giant, and today is with NIM, which is, he'll tell you a little bit more about the company, but I can tell you they are growing rapidly, they're hiring, and they've got fabulous offices to which I have been. So over to you, Julian.
Well, thank you so much for the introduction, Bunny. I don't need any further introduction. Though I'm the SVP and head of commercial at NIM. NIM is an autonomous medical coding platform. So we code medical records with a 95% accuracy, less than a second, and more importantly, with absolutely zero human intervention. And we serve emergency departments and urgent care centers throughout the country, which is one of the reasons to have this panel today. And essentially, we make sure that they get paid by submitting accurate and compliant bills to payers.
Fantastic. So we've got a great perspective here. We also had a lot of audience questions beforehand, so that's exciting. There's a lot of interest in this topic. I mean, and why not? Urgent care really developed because people wanted on-demand care. So why don't we start with COVID? And, urgent care had already been growing. What was the impact like on each of your businesses? And maybe Vivek, we can start with you.
Absolutely. We have been in a position to provide access to testing and vaccinations for the communities we serve, and it's been quite fulfilling being on the front lines. Having said that, there's been meaningful challenges, supply chain challenges, staffing challenges, staff members testing positive, dealing with the challenges associated with wait times, and then also the changes with respect to the different surges. We went through the Delta surge in August, and now we're going through a new surge associated with the Omicron variant. So there have been challenges, but over the past 2 years, we've continued to adopt and we're become a nimble organization ready for those challenges. In terms of volumes, industry trends, before the pandemic, about 5% of urgent cares in general, we're seeing over 60 visits per day. Now, over half of those urgent cares see that type of volume. So it's truly been a paradigm shift into how consumers perceive and utilize urgent care services.
What about you, Eve? How has it impacted Lenox Hill, the ER?
Well, yes, I think it's related with what happens in emergency departments and urgent care. The first unfortunate news is during the first surge that we had a certain subgroup of our patients that just didn't show up. Those were patients the most ill, strokes and MIs, et cetera. So that was unfortunate. But then I think that the consumers also on the other spectrum learn that there are alternatives to healthcare that are just as viable and safe, and chose to leverage urgent care and telemedicine to a great extent. And I think those experiences through COVID, and usually there's a very good patient satisfaction in these settings, will then continue to be an alternative for patients moving forward. We know that in 2019, about 30% of patients had at least one visit in urgent care, if not more. So I think that trend is just going to continue.
Sunny, how about you?
Well, so the first thing that happened in our business when the pandemic really got going was our walk-in volume, which was almost all of our volume, dropped by half. Just extremely quickly dropped by half. And we knew that wasn't going to come back quickly, and it didn't come back quickly. It came back, but it was not quick. And we, of course, have another little wrinkle in that our clinics are located in the middle of a retail environment. And so we had it was probably just as well that volume dropped because we needed to get a handle on how you handle the question of COVID positive or potentially COVID positive patients walking into a healthcare clinic that might be in the far opposite end of the store from the front door. And how, because whatever you do in our setting, you've got to turn and face the public with it and own it with the public. And so we had to wrestle with that, and we've wrestled with that in a very conservative way with respect to traffic in the stores. And then the final element for us was stepping into testing in a big way. We have an asset of, thousands of thousands of stores throughout the country. And the ability to leverage our pharmacy partners to help us in a testing environment. And we have at least three different models of testing, and we've done tens of millions of COVID tests. So that really stepped into the vacuum that was created by the loss of volume.
Julian?
I mean, what we have seen is very much aligned with what was just said. I think I would identify the most to what Vivek described in terms of the increase of volume. But I think we can all recognize that urgent care centers played a crucial role in dealing with the pandemic, especially in urban areas. The vaccines, of course, testing. I got my booster shot last week at the urgent care facility, right next to my place. What we saw more on the back office side is, of course, the increase in volume and the disproportion of COVID cases kept people really busy and frankly overwhelmed. Some of them had to like spend days going through like medical records and then coding them. We saw a few urgent care groups accumulating sometimes months worth of backlogs, and then creating some burnout and missed revenues. And on top of that, I don't think it has been mentioned, but CMS was not making things easier by bringing like new guidelines, new ways of coding, and then payers were using this to actually deny the claims for some of the urgent care centers. So some of them were really between a rock and a hard place. And frankly, all of that was one of the reasons we invested on the urgent care side. At first, to clear the backlog, so automations could clear in a few hours, like months of backlogs in just a few minutes. But then over time also to create some real-time revenue cycle management and coding solutions for that.
So a number of forces have, COVID unleashed a number of forces, right? That impacted everyone. And clearly the, virtual care has really come into its own at this point. And so how is the virtual, we called this is click-and-mortar better model. So how is virtual impacting physical, and where do you see things going? And feel free to jump in.
I'll jump in. I think in the New York market, we're all friends and we tend to be competitive, but to be honest, NYP has been on a journey in terms of telemedicine in a big way for a while. And they were able to leverage that. NYU was able to leverage it significantly also. They've actually published their findings in terms of telemedicine. It grew exponentially. And they onboarded, hundreds of providers who had never used telemedicine. And I think that's an important component. There is a skill set that's required as a provider to really try to interact with your patient in a meaningful way to give them the same experience that they would face-to-face. So I think there were a lot of lessons learned during that time through telemedicine. And I think the other key component of telemedicine, it actually serves to be kind of a triage, so to speak. So the patient who's uncertain of what to do 3 o'clock in the morning, or quite frankly, anytime, can talk to a provider who could guide them and say, look, you could stay at home, this could wait, do such X, or this needs to go to the emergency department. And in general, the conversion to emergency departments is a very low percentage, less than 5%. So that goes to show you that a lot of this can be managed successfully through telemedicine.
I'll jump in. This is Dr. Morton. I'll jump in and I agree with what Yes just said. If there were any people on either the public side or the provider side, the healthcare provider side, who were hesitant about virtual care, we're stuck in the 20th century. As Yes said, there was a lot happening prior to COVID, but COVID yanked you, into the 21st century in a very big way, and it was a fairly broad appeal, because I think, even older folks who were particularly worried about potential exposures, at a healthcare facility, we're used to thinking of youngsters as the people who adopted, and that is true statistically. But I think COVID made older folks take a second look at that and say, you know what? If I can pick up this new skill, it will save me having to go out into what is now a dangerous environment. And so I think it pulled everybody in and across. One thing I will say, though, is with all the attention on virtual now, brick and mortar's not gone. There is always going to be a place for brick and mortar, and what we're going to spend the next 10 years or so figuring out is what's appropriate for virtual, what's appropriate for brick and mortar, and where do they fit together, and how do you make those handoffs? So that's the next exciting frontier in front of us, I think.
Yeah. I agree in that we're seeing new paradigms of care. It's not this binary in-person or virtual. What we're seeing is this omni-channel experience. And what I mean by that is I've talked to surgeons who've operated on patients for the first time. And that was the first time I actually met them in person. They might do a telehealth visit. The urologist might send them to get an MRI, and then they would operate on a kidney stone. And I see that paradigm shifting in urgent care very similarly. You might have a virtual visit to do a swab only at a center, so a very quick, expedited experience. Or you might do a virtual visit for a urinalysis if you have a UTI, and then you might submit a urine sample or a blood draw at the urgent care setting. So it's really this omni-channel experience that we're seeing. And I think we're gravitating toward this new paradigm in that, like, who really goes to a bank teller anymore? We have the ATM, and it's become the paradigm, and it's become the default almost rather than the alternative. And that's, I think, what's starting to emerge.
So what are some of the new models that you've seen, and which ones are most interesting to you?
So if I can jump in, I think what Vivek described and what Dr. Morton said about brick and mortar not like going away, and it's more actually is a hybrid model that's about to develop. To use the analogy of banking, I mean, you still go to the bank, right? You don't do everything on your phone. And there has been a number of providers who have been extremely creative in the use of telemedicine lately. If you look at companies like Carbon Health, for instance, or some of the at-home urgent care models like Ready Responders, for instance, they don't do a telemedicine consult between the physician and the patient. Instead, you have the patient meets with the nurse or some local clinical staff that has an iPad. Then that person brings in just in time the physician for what truly matters, right? It's an accurate diagnostic. And then by doing this type of model, you're able to be a lot more efficient and allow the physician to provide a lot more impact to a lot more people. And then also, I think it has allowed them to scale very quickly, because it's just very efficient from an operational standpoint. And on the revenue cycle management side, these were actually the first models to really think about automation from the beginning, because they were entering new markets almost on a weekly basis, right? And they could not just hire 12 new or 10 new coders every time they would enter a new market or a new state. And so, yeah, automation for them was kind of like the default step and a condition for their ability to scale.
I want to pick up on Julian's point about the at-home model. So that's another model that's going to blossom most likely. And, you know, we have a generation of folks who are used to just in time for whatever they need in terms of merchandise, in terms of Uber, etc. And so there are some companies that I've advised in the past, Pager, Leah, that are currently out that are doing just that. You get a provider to your home. And I think that's a convenience. That's the next step of level of convenience. And I think eventually we're going to bring labs, and we are at Northwell. We partnered with FlyLab. We're bringing labs to the home. And I think we're going to start to see imaging that's being done at home. And all of these things are going to continue to evolve. But I think each part of that ecosystem is going to need each other. But I think eventually we'll start to get people in the right setting at the right time for the best care. And I think that's, yeah.
And Bunny.
Oh, yeah, please.
Yeah, I'm sorry, if I could jump in with one more little tangential issue, but I think it's becoming an increasing part of healthcare. In the Minute Clinic model, it's long been one of the things we have to deal with is physician oversight of NPs and PAs. That's a state by state regulatory environment. You know, it changes state to state, but still in over half the states, NPs do not have full independent practice, and in no state does a PA have full independent practice. So they require a physician, and that physician oversight as virtual modalities develop and as systems develop and as everyone gets more comfortable with it, it does provide some interesting, you know, I'm taking off of the comment about, you know, interaction with a nurse and then you bring a physician in when you need them. Same thing can happen at the level of an NP or a PA, is you can have a physician covering, because they're not limited geographically, covering a lot of NPs or PAs available when they're needed. And, you know, along with the increasing use of advanced practice providers overall anyway, I think that's going to be an interesting thing.
So it's very convenient, right? And as you both noted, you know, right care, right time. Okay, but what about number one, continuity of care? And number two, you know, I'll be honest, like I've used urgent care as primary care. I just have. And so my records are still spread all over the place. What's the relationship between urgent care, primary care, and then continuity of care?
I think,
Okay. I think it's very important to have a very symbiotic relationship with the primary care network. So our primary care networks, they might refer to us if they're closed. And so we can be sort of the aftercare apparatus, so patients can access care at night, and then we might get a consult note back to them. So there's that symbiotic relationship. I think you're also referring to just pure how urgent care has evolved. When I've talked to physicians, they've talked about the treat them and treat them model, where you just, they don't really like being that doc in a box where you treat them and treat them. They want to make sure that they know the patient coming to their center and they coordinate the care afterward. And it's this connected experience. I think that's the value of having partnerships in place. So whether a patient needs an inpatient referral or whether they need to be connected to a cardiologist or an orthopedist or sending your consult note to a primary care, I think that's the truly where urgent care is going to be evolving. I got a thank you note 2 days ago from a patient who was referred to an ER from one of our sites in Mineola, Long Island. And that patient was a 26-year-old who had blood clots in her lungs. And it was a thank you note saying, we discovered something and you saved my life. And I think that continuity of care, connecting you with the ambulatory network through EMRs that are interoperable, that is truly the paradigm shift that we're migrating toward as a system.
So I think it's very important also in terms of the medicine and the science and who actually needs primary care. As you look at younger groups, if you're healthy, you're in your 20s and 30s, you know, even all the leading AMA will tell you, you know, you only need maybe 2 every 3 years. As you get older, obviously you need more visits. And so the young folks know that. But I think the challenge for urgent care is also to be mindful of also being involved in preventative care. So if I have a 50-year-old in front of me and I do this in urgent care, I will ask them, you know, have you had your prostate checked? It's time for your colonoscopy, you're overdue, et cetera. So I think those are quality measures that urgent cares have to put in place to assure that we're not just, quote unquote, treat them and street them. So I think that the quality of care, and I think there was a question about the quality of care that came through, that's very important. But, you know, back to Dr. Morton's point about regulation, I think we have to be very careful, and there's a balance there. I think what's made urgent care so successful is actually in some ways they're not as regulated as historically the hospitals and emergency departments. And by getting out of the way, we've actually caused less friction in terms of you being able to get in front of a provider. So if you come into my emergency room, there are at least 10 questions I just have to ask you. And all of these things, legacy-wise, over the year has created really roadblocks in terms of getting in. So I think there needs to be a balance in terms of regulation, but the quality, we have to always make sure that that's front and center no matter where the patient is, be it at home, telemedicine, urgent care, or emergency departments.
I will say that I look at this from the patient's perspective, and having been through a similar some healthcare experiences with a parent recently. From the patient's perspective, they really don't get why they have to keep repeating themselves. Why they have to tell the story first, to the urgent care center, and then, to the ER, and then to the consultant, and they expect us to be able to figure this out. In an ideal world, there would be just one giant big EMR and everything would be in there. But until we get to that world, I think this is what's going to drive a lot of integration. It might not all be buying people, although it might be, but I think it's going to drive a lot of partnerships and a lot of deep enough partnerships to invest in the systems that make it where the person in the urgent care center, in the primary care doctor, knows exactly what happened on the televisit a couple of days before. And in fact, the scheduling, it wasn't that the patient had to make a separate phone call to get scheduled. It all happened. That's what the patients expect from us. So I think you're going to see a lot going on there as we go forward, binding those things together through one way or another.
So would it be fair to say, I saw CVS, recently announced that they were going to be expanding, right? The Minute Clinic's footprint quite a bit. Will you consider that like somebody's medical home, right? Or like what's behind that expansion?
We don't yet. We're not a medical home yet. Don't claim to be. Don't have a timeline. But if I said we weren't thinking about that, everybody here would laugh at me. We are thinking hard about it, and I think others know more about the payer side than I do. But we've had hanging out there for 20 years the promise of value-based care, and value-based care can't really happen until you control the whole patient experience. That's where you get the bang for your buck in value-based care. So I think every urgent care, well, I shouldn't say that. I can't speak for urgent care. Others here can do that. But certainly for Minute Clinic, we recognize the need to be aiming at the medical home and figuring out either how we are going to be it or how we are going to partner tightly with it.
So do you see urgent care and primary care sort of merging over time? Or what's the scalability, of urgent care long term? Julian, maybe you want to chime in?
I cannot answer too much on the primary care versus urgent care. As a patient, of course, like I'm assuming a lot of people, CityMD at some point became my primary care provider. No, I think on the scalability, though, one aspect that is really that is overlooked but crucial is actually the revenue cycle management aspect. And we know, or at least I know, a few urgent care providers that are in this hyper growth model, and that are frankly still trying to get paid for visits that they had in 2020. So ensuring that they get access to a scalable revenue cycle management, to some level of automation, that they don't need to rely on manual coders every time that they want to expand in a new market, I think is a pretty big factor or limiting factor in scaling this type of businesses.
Well,
so Bunny,
yeah, go ahead.
So I think it's a very good question in terms of the primary care and urgent care. We have to appropriately get the patients to the medical home. Urgent cares are not designed for, it's for episodic minor care. And we at GoHealth, and that I think that was why there is such a partnership between GoHealth and Northwell to make sure that we plug the patients in appropriately, be it for referrals or primary care. And so there's a question about this on the chat, and I think the answer to it is that we've put a lot of, and Vivek could speak to it, behind the scenes that tracks, abnormal labs and tracks the patients and make sure that they get to that next place that they're supposed to be. CityMD has a 24/7 aftercare program also that does a very similar thing. So I think we're very mindful of that. And that's why you'll see these various relationships between urgent care centers and your traditional primary care, specialist care, and system hospitals.
Yeah, I'd agree with Eve in that the role that we play is very dependent on the partners around us. And urgent care can provide care up to life-threatening care. They can be involved in management of chronic disease, but it's the episodic care that we have defined ourselves with. And when it comes to episodic care, management of chronic disease and other disease factors related to primary care often depends on the access available in the community. So we have locations. We have a location in Left Rack City, Queens. And when I talk to providers there, they often say, we practice by the way medicine. So it's a patient comes in and says, hey, can you look at this pink eye? But by the way, can you look at this? Can you look at this rash? It's because the access might not be in that community. And we continue, and you mentioned scaling, Bunny. We are scaling because, as a matter of fact, we're actually opening another site in Queens next week. In a site that in a location that can benefit from greater access to care. And to the extent we can provide that continuity with our network of relationships, we want to be very involved in that. But given the needs of the community that they have and the access they have and being time constrained, we also want to be able to, if for example, if our health system partner needs us to play a role in providing annual wellness visits because we're more closer in the communities to do that, we do that. So that's kind of how we think about it.
Is there anything that technology hasn't, or what more can technology do to improve the overall urgent care experience, whether physician patient or administrative? Like what are the big holes that we should be thinking about for tech? Given that New York is the digital health capital of the world, we know that.
I'll speak from the perspective of a provider. And I think we often speak of EMRs from a patient perspective, which is appropriate. But from a provider perspective, it actually needs to be not so clunky, not so bulky, not to get in the way of our interaction with our patients. And I think that's the biggest challenge. And that's why, if you go to urgent care, you'll often see the provider with a scribe. And that's just a surrogate marker for the fact that EMRs are not as efficient as they should be. And the other important thing in terms of the urgent care is the documentation that's needed is not necessarily the same documentation a primary care doctor's office would need, or even an emergency department, or my need to look up historical data for an episodic non-emergency situation may not be the same. And so it's not a one size fits all in terms of EMR. And I think we have to be mindful of the workflow of the providers. And we also have to be mindful of what real data elements are necessary to conduct that specific visit. And then that goes back to telemedicine also. So that's one of the challenges when we were standing up telemedicine at Northwell Health. We couldn't, our current EMR really didn't fit that model and that flow.
Just to add on what Dr. DeRosa said, the workflow component of that is one that I've yet to see any company cracking, because it takes a village, right, to take care of a patient. And at the center of that village, you have the EMR. And no two health systems are wired the same way. So you need actually technologies that are really flexible in the way they can incorporate, and I see some people nodding, but in the way they can incorporate these workflows. Also because new technologies coming to health systems highly depend on the EMRs. You have the same issue over and over. We see it when we integrate with health systems. There's some rewiring that needs to happen on their side, and that's actually like some work that needs to be done. I think having EMRs that can be more flexible, more modular, I'm not sure exactly what the word is, but in terms of accommodating, customizing, defining workflows without having a team of like 10 IT people and some external consultants coming in would be an amazing progress.
Yeah, it takes a city of people 6 months to get anything done in your EMR.
Yeah,
it's crazy.
Right. Go ahead, please.
I was just going to say the IT function, the need to update the EMR and to build anything that needs to be done in the EMR is one of the few functions that can actually just take a big company and just make it stop and say, just because they say we can't get it done that fast. Everybody else, you work overtime, you do whatever's needed, but it's just it amazes me. I'm constantly amazed, and I'm gonna not really bellyache for too long here, but it constantly amazes me how long it takes to get anything done in EMR. So it is. I'm just like nodding to that comment and going, yes, it's let me go ahead and throw in one other thing. Let's not forget peripherals and remote monitoring. That I think the technology is sort of there. A lot of what's holding that back is where does the information go when you collect it? They've built some pretty neat gizmos to, give you all kinds of data from the patient's home. But where does it go?
So we have a very active and inquisitive audience, which is fantastic. It means this is really a topic that is interesting to people. And I like to have people actually ask the question themselves. And so I hope you don't mind, but I thought Daniel Eden had a great question. And I hope that you will, so you'll ask it. Daniel, can you ask your question and just briefly introduce yourself?
Sure, yeah. Thank you everyone so much. This has been really interesting so far. I am one of the chief residents at Cornell in psychiatry. And I was curious, obviously there's a whole infrastructure which you guys are talking about and needs more development. On the medical side, I've been struck sort of rotating through psychiatric emergency rooms through my residency that there are still a lot of inappropriate sort of presentations in that setting on the behavioral health side. And not a lot of infrastructure thus far for building urgent care as an on-demand access to care in the mental health world. I know some people have started to do this, but I'm curious sort of what the challenges have been and why maybe this is lagging behind the medical urgent care side.
I'll start from a perspective as a provider. I think to your point, we have examples. Our first use case out of emergency medicine in terms of telemedicine really had to do with the psychiatric patient, and I was skeptical, to be honest, initially that a psychiatric patient would engage in such a way, and I've actually found the opposite. The ability to get someone in front of them makes all the difference as quickly as possible, and just someone to listen. And I think in your field in psychiatry, it really does take an amount of time that urgent cares are not necessarily set up to. If, Vivek is telling you numbers of, you imagine 60 visits in 10 hours. I've been in situations where we've done 20 visits in an hour, believe it or not. That's not a model that's necessarily conducive to mental health. But I think having said that, you probably can design a way for the appropriate established patient to get into. And at the end of the day, to be honest and frank, it comes down to reimbursement. All of that we're talking about, we really haven't focused on reimbursement. By and large, unlike emergency departments that have a mandate, unfunded mandate to take care of whoever walks in, urgent cares are not set up in that way. They really take commercial. It's mostly 50% commercial. The rest is 25 or so Medicare, Medicaid, and 10% cash. And then there's workers' comp in that mix. So we really have to talk about the reimbursement to really answer that question also.
And Dr. Eden, if I could jump in, I did want to point to one, either call it a success story if you're looking at the cutting edge, or an impending success story, which I think will be borne out over the next few years in the field of psychiatry, which is substance use disorder. A lot of that's going online now quite successfully. So maybe there'll be some lessons there for the rest of us.
So Julie, on the, Eve brought up the reimbursement, right? And that's sort of in your wheelhouse, right? About how, can you talk a little bit about how that might, how you might be able to help that?
Yeah, well, so it may be helpful for the audience to explain like coding and how providers get paid. I think that Dr. DeRosso, you gave a really good example with the breakdown of the payers for urgent care centers. But essentially, there's a coding system for providers to get paid by payers. Hospitals and physician groups, they rarely share your medical record directly with the payer. Instead, they turn the medical record into a set of diagnostics and procedure codes. These are the famous ICD and CPT codes that then get put on a claim, and then that's sent for reimbursement to the payer. And so literally today you have hundreds of thousands of coding, like codes that cover anything that can happen in healthcare. And it's both pretty complex and very precise too. It's complex because in the case of an urgent care visit, we are talking about 10 pages of EMR that you need to screen to find the right diagnosis and procedure. For an inpatient stay, it can be hundreds of pages, and it's both structured and unstructured data. It also has some intrinsic complexity and complex logic in other, like how these codes are built with tons of rules on how you can assign them based on what happened during the encounter. And then there's also like a precision problem. Like if as a provider, you are too vague in your codes, right? You just assign blanket codes for everything. Eventually, you're not getting paid for the complexity of the care that you provide to patients. On the other hand, if you're too precise in your coding, then you do what's called overcoding and overbilling. And then at best, your claims will be denied by the payer. At worst, OIG is going to give you a phone call one day. So there's a great deal of automation that can happen there. It has been a long time, like fantasy, frankly, to be able to automate all of that. The way we do it at NIM is essentially a 3-step process. You take the unstructured or semi-structured data from the EMR, you turn it into a fully structured clinical narrative, so you understand what happened to the patient, who did what, when, for what reason. And then you apply a coding logic to that clinical structure to find the right ICD and CPT codes. And without going into much details, we use something we have developed that's called clinical language understanding. It allows us to do that full process in less than a second and code with like very precisely 95% accuracy. And you can hope to automate 50 to 60% of any provider's volume by doing that, at least in the urgent care and emergency department setting. And not only you have operational efficiency gains, but also, and that's the link to Dr. DeRosa's point, you make sure that they are being paid for the complexity of the care that they have been delivered and hence to the right amount. So I hope that was a good crash course on coding. Happy to develop more after.
It's called fee for service. And that is how involved it is.
Yeah.
We have another question from Joshua Stidham. Joshua, are you able to ask?
Yep, you did a great job with my
Hi.
last name too.
Tell us
Hi.
who you are, where you're calling from.
My name's Joshua. I live in
Oh,
Brooklyn.
good.
Yeah, and you pronounce my name perfectly. And I'm a commercial strategist at Capsule Pharmacy. And so my question is, well, first of all, thank you for all of the conversation that everyone had. It's been really interesting and insightful to hear how everyone on this call thinks about virtual care, especially after COVID really changed the game in a lot of ways. So my question specifically and selfishly, how does this group think about the pharmacy experience in relation to urgent and virtual care? Mine is CVS, because you guys have a one-stop shop model. How do urgent care centers prioritize and coordinate pharmacy partners and ensure patients get their meds? And is that important to urgent care as well?
And I will say that it's not even that easy for us, side of the house, you know.
So I would jump in. It's incredibly important. It's incredibly important for us to know the pharmacy, and we try to capture that information, frankly, in advance. We try to make sure that we have the address and phone number of the patient as they register, and we try to be in the communities so that access to pharmacy is actually quite easy. So to give you an example, I live in suburban Long Island in Port Washington. I actually live walking distance to a GoHealth urgent care, and next to that, adjacent to that, is a Stop and Shop grocery store with a pharmacy. And I think our presence in the community, our proximity to pharmacies, our intake process for getting information and making sure we have the right directories and contact info to make sure scripts are sent and filled, as well as our follow-up process with patients as needed, is critical to patient care delivery. So no, thank you. That's a great question, Josh.
Yeah, that's a very good question. I want to address it also from a quality standpoint. We're talking about convenience, and also, but we have to be careful and mindful of, we can't be overly convenient in terms of what we prescribe. So what I'm getting at is antibiotic stewardship. So that is one of the things that urgent cares have been focused on. It's not a matter of just dispensing that Z-Pack to make the patient happy. So I think there is a balance in terms of also how we educate the public, and that we don't just become a place of overly convenient and create unintended consequences in terms of antibiotic use and any medication use. The other challenge for providers is we're often at a loss for what that person's insurance is going to cover. So we're talking about technology. It would be great if I were to have an immediate verification of a medication. So one of the most frustrating things, as you're seeing those 6 to 10 patients an hour, to have to stop to help reconcile a medication that the pharmacy, Dr. Morton's, I'll pick on him, outfit decides that they're not going to pick up. So that's, I think, another advancement we can make in terms of automation and technology.
I'll also just point out that as pharmacists, like other healthcare professionals, become more empowered, an awful lot, at least inside our stores, an awful lot of vaccines are given by the pharmacist, and makes exchange of information even more important. And I don't think that's going away either. And so the exchange of information and making sure that all of that information is integrated becomes even more important.
Thank you. We have a question from Joe Tomeno. Joe, are you there?
Yeah, hi, Bunny.
Hey, and
How are you?
Hey, Joe. Good.
Good. So I'm Joe Tomino. I'm CEO of GoHealth Advisors, and since COVID, we've been seeing the growth in urgent care. We've been working with investor groups and setting them up. But one of the questions I had relates to the whole notion of primary care in urgent care, and I know one of the issues is that if you're going to be successful in urgent care, you really want to have rates with payers that are urgent care rates, and you don't want to have primary care rates. Obviously, the urgent care rates are reflective of the value proposition of ER avoidance, and they don't want to pay those rates for things that could be done by primary care. So do you see something like the model that CityMD is setting up with Summit, where you have a primary care hub that services half a dozen urgent care centers? So you have the urgent care centers who, when they identify someone who needs primary care, can connect them with their hub for that follow-up. Do you see that as being a model that is both clinically and financially desirable going forward?
I think clinically it's appropriate. I think that's, and we spoke about that, and I think that's why CityMD is partnered with Summit, why GoHealth is partnered with Northwell Health. From a quality clinical standpoint, that would be, it is ideal. One of the things that financially we haven't spoken about, the concern for emergency departments were that we often relied on our high margin, low acuity care, because quite frankly, in the setting of emergency department, you win by taking care of someone with a minor sprain, laceration, because of the resources expense side is not as exuberant. But when we take care of the sickest of our patients, the septic, the ones with the heart attack, and we're throwing a lot of resources, we tend to lose from an economic standpoint. So I think from an economic standpoint, why it makes sense for Northwell to also partner with urgent cares is that so that we don't lose that stream of revenue. And I know that sounds like that's the business hat of me, but I think that has worked very well, both from a quality perspective and also by the fact that we are also driven by the economics, and that's just a reality.
Joe, I've been advocating for variations on your wheel and spoke theme for 10 years. Just makes sense to me.
And the other important part of that is, again, it goes back to the EMR. So I think with Summit and CityMD, they had two different electronic medical records, and they've recently merged to one system. So you would have to speak to the providers about how they feel about that. Maybe not such a popular move on the urgent care side, but necessary for that continuity of care.
Yeah, I think it's critically important to have a very frictionless experience as you create that hub and spoke model and you refer to primary care. When I was with Optum, it was not atypical to have co-located primary care in the urgent care setting so that you can literally make a warm handoff to our primary care physician, and that takes place. And that's why the density of the ambulatory network surrounding the urgent care network is critically important. And we're seeing different paradigms of that surface.
So we have just a few minutes left, and Sunny, something you said earlier struck me about partnerships and relationships and the consolidation, which I think we're going to see a lot in 2022 among the digital health community. So longer term for all of you, which models do you think are going to be most successful, and you know, who do you see maybe combining? Or who should combine? Eve?
Okay, Dr. Martin, you were, okay, so I
Well,
think,
she brought up my point, but I'm gonna defer. I'm gonna defer. I'll be very general to start with. Agree. I think that there's even more impetus now for various combinations. Personally, I think it is going to be I think it's going to be the big guys buying the small guys. I think not that this is, I'm speaking to CVS specifically, but it's going to be CVS buying a telehealth company or buying some regional telehealth. And not that we're doing that or talking about it. I'm just giving that as an example. I think it's going to be the big guys buying the small guys, not because there's something special about this time around, but rather the opposite, because that's the way it always happens. Big companies innovate by buying small innovators. And I think that's personally what's going to happen. I wouldn't begin to know or comment on who ought to buy who, but I'd like to hear somebody else do that.
well, I think there's another player here. The elephant in the room are the Ubers and the Googles of the world, the Amazons of the world. They have tried in multiple different iterations, but I think they're going to get it right. And I think what they're focused now are on their employees as a kind of experiment, so to speak. A lot of them self-insure, as we do at Northwell Health. And I think we're going to continue to try to figure that out, but I think they are going to be major players. It's not ironic that Amazon bought Whole Foods and may try to go compete with Dr. Martin's space there, or in terms of pharmacy, et cetera. So I think those are players to watch. But as we speak about all of these things, I think we also need to be mindful of still our uninsured patients or vulnerable populations, and where do they all fit in this, and what are our responsibilities for those populations?
Well, on that note, that's another webinar or event that we should definitely have in the future. So wanted to thank our 4 panelists. Thank you, Eve, Vec, Sunny, and Julianne. I want to thank NIM for helping organize this. And they are a New York-based company. As I said earlier, they're hiring, and just wanted you to know about them. And we are excited to hopefully see everybody live in February. In the meantime, I hope you don't need to go to urgent care, or I hope everybody's good and well, and have a really wonderful holiday. And hopefully that we will see you in 2022. Thanks again for participating, everyone.